Okay, welcome back, everyone. It is now 12:16 Eastern Standard Time, and we'll go ahead and get started with this next session. We are going to get started with Dr. Ruth Link-Gellis speaking about vaccine effectiveness studies in the U.S., followed by a presentation from Dr. Rachel Slayton on modeling the impact of booster doses in nursing home residents. So we'll go ahead and get started with Dr. Ruth Link-Gellis.
Thank you, Dr. Lee. Today I'll be presenting a summary of vaccine effectiveness data available from CDC platforms or published via CDC's Morbidity and Mortality Weekly Report. Next slide. CDC uses multiple platforms and study designs to monitor COVID-19 vaccine effectiveness, or VE. These designs monitor both duration of protection and protection against variants by risk groups, outcomes of interest, generally infection and severe disease or hospitalization, and products. While not every platform has the sample size to cut data by all of these categories, we've attempted to present data today from each platform in a way that will be most meaningful for the questions at hand while not cutting the data too finely. Next slide. The first platform, the Increasing Community Access to Testing, or ICAT partnership, does not specifically focus on any of our populations of interest today. However, with nearly 1 million observations from the general population, it allows a unique opportunity to truly tease apart waning against infection pre-Delta and during Delta, so we've included it here for background. Next. The ICAT platform includes community-based testing data from pharmacies and partners nationwide. It uses a test-negative design, and importantly, vaccine history is self-reported. For this analysis, only individuals reporting symptoms were included. Data are presented here for ages 20 to 64 and adjusted for time, race, ethnicity, gender, HHS region, state, and site census tract social vulnerability index. No adjustment is available for underlying conditions or prior infection. Next slide. I'll show a series of graphs of VE against symptomatic infection by age group for each vaccine, starting with Pfizer. In green, we have pre-Delta VE, and in red, VE during Delta. Lines are 95% confidence intervals. We can see waning in both time periods with lower VE and more waning during the Delta period. Of note, the curves for all age groups look similar, with VE around 65% by 200 days after the second dose. Next slide. Here we see the same graphs, this time for Moderna. VE tends to be roughly 5 to 10% higher for each age group compared to Pfizer, with VE between 65 and 75% by 200 days after the second dose. We see the same general pattern with more waning and lower VE during Delta as we did with Pfizer, and again, the patterns are similar across age groups. Next. Finally, we have the same graphs for Janssen. This time we see VE actually increasing by time since vaccination, which matches the data from the Janssen RCT. The effective Delta here is a little murkier, and of course there was less pre-Delta follow-up due to the later rollout of Janssen. Curves here again look similar across age groups, with VE 200 days after vaccination during Delta up to around 55%, so about 10% lower than Pfizer. Next slide. As this is such a large data set, I do want to carefully highlight the limitations, including self-reported vaccine history, which resulted in dropping about 18% of the data. We do not have data on comorbidities, prior infection, or behaviors, and since there are no individual-level unique identifiers, analyses are based on tests, not individual people. Finally, there are no genetic sequencing results, so time was used to differentiate Delta from non-Delta. Next slide. I'll now focus on platforms that include data on individuals 65 plus, including residents of long-term care facilities. Next slide. COVIDNet is a population-based surveillance system that collects data on laboratory-confirmed COVID-19 hospitalizations through a network of over 250 acute care hospitals in 14 states. Cases are residents of the surveillance area with a positive SARS-CoV-2 test within 14 days prior to or during hospitalization. Using immunization registry data, investigators estimated VE against hospitalization during April to August by age group. VE was calculated using a variation of the screening method through a Poisson regression model that allows control for calendar time. Importantly, this method does not allow for adjustment for other important confounders, including comorbidities and prior infection. Next slide. Here we have VE for the mRNA products by age group over time during April to August from COVIDNet. While this slide represents Pfizer and Moderna vaccines combined, approximately 71% of the vaccinated cases shown here received Pfizer, although this may be an artifact of most residents of long-term care facilities participating in the federal distribution program receiving the Pfizer product. As you can see, VE remained well above 90% and highly overlapping for all ages up to 74 years, but trended lower starting in June for those 75 years and up. VE for this age group was around 88% in July and 91% in August. Next slide. COVIDNet gets detailed clinical and vaccination status on a representative sample of patients on a monthly basis. Excluding partially vaccinated patients and those who were fully vaccinated but had evidence of prior SARS-CoV-2 tests, these included almost 6,000 cases, of whom 92% were unvaccinated. This table shows characteristics of unvaccinated and fully vaccinated hospitalized cases and highlights that statistically significant differences in demographics and underlying medical conditions. In general, fully vaccinated persons were more likely to be older with a median age of 72 compared to 59 in unvaccinated persons. 72% of breakthrough cases from January to July were greater than 65 years of age, compared to only 40% in unvaccinated. Vaccinated cases were also more likely to be residents of long-term care facilities and more medically fragile, as evidenced by significantly higher proportions of people who had a DNR/DNI code status on admission and more underlying conditions. Additionally, as you can see here, COVIDNet found that the number of underlying conditions were higher in fully vaccinated persons, with half of vaccinated persons having cardiovascular disease compared to only a third in the unvaccinated persons. Next slide. The New York State Department of Health recently published an MMWR using linked laboratory immunization and hospitalization records, and today we'll share an update of their analysis that includes over 150,000 observations. Over 90% of their population received mRNA products. Next slide. Here we see time on the x-axis and VE against infection on the y-axis. The increase in delta is plotted in the dotted blue line, and changes in mass guidance are noted at the top of the graph. As you can see, there was a decrease in VE against infection in June and July for all age groups as delta surged, and then a leveling off of VE against infection in July and August. Next slide. This is the same graph as the previous slide, but with VE against hospitalization instead of infection. Here we see VE against hospitalization remaining relatively stable for all age groups, with a slight decline for the 65+ age group shown in orange during the Delta period. Next slide. VISION is a multi-state network, including electronic health records from 187 hospitals. VE was calculated for adults 18 and up, with investigators comparing hospitalized individuals with COVID-like illness and PCR-confirmed SARS-CoV-2 infection versus virus-negative controls. VE is adjusted for propensity to be vaccinated, calendar time, region, local virus circulation, and age. Models for Waning use 6 of the 7 total VISION sites. Vaccination is documented in the electronic health records and jurisdictional immunization registries. Next slide. Here we have Pfizer on the top in gray and Moderna on the bottom in yellow. VE is broken down by age group and time period shown along the bottom, with the darker bars being the pre-Delta period and the lighter bars being the Delta period for both products. Here we see fairly stable VE in the 2 time periods, with the exception of the 65+, and a bigger decrease specifically for Pfizer with non-overlapping confidence intervals. While there's a hint of decrease for the Moderna point estimates in this age group, this was not statistically significant. Next slide. Here, VISION has VE against hospitalization for all adults split out by time period, January to March, April to May, June to August, and then subsetted by time since vaccination, with the darker blue bars reflecting VE in the 14 days to less than 2 months since vaccination, all the way to 5+ months since vaccination in the lightest color. Next. We see here in the red boxes that among people recently vaccinated, VE against hospitalization has remained high in all 3 time periods. Next. And finally, in the Delta period from June to August, VE has declined among those who have been vaccinated for longer periods of time, with a statistically significant decreasing trend. While this shows VE for adults ages 18 and up, not just the 65 plus age group, we expect that waning to be the same or worse in older adults. Next slide. And finally, since we have so little data on Janssen, I wanted to share this comparison of the pre-Delta and Delta periods. Notably, these are pulled from previous publications, and due to small numbers, Vision was not able to show a specific 50-plus estimate during Delta. We see a decrease in the point estimate for VE, although with wide confidence intervals. And if anything, the comparison of an older age group in pre-Delta to younger age group during Delta would bias towards less decline. Next slide. The National Healthcare Safety Network, or NHSN, is a healthcare data reporting system. For COVID-19, nursing homes report the number of residents in the facility by vaccination status, and the number of COVID-19 cases in residents also by vaccination status on a weekly basis. Investigators estimated VE for infection for 3 periods: the pre-Delta period, the intermediate period, and the Delta period. Reporting to the platform became mandatory in June for CMS-certified skilled nursing facilities, so the number of facilities reporting rose steadily during the study period. Next slide. Here we see results for each of the periods on the bottom, with overall results for both mRNA products on the left, Pfizer in the center and Moderna on the right. VE for both products declined from almost 75% in the pre-Delta period to the low 50s in the Delta period and did not differ substantially by product. Next slide. In summary, for individuals 65 plus, we saw large declines for mRNA products against infection, shown here in blue. The largest decline was from a platform focused on the LTC residents, although New York State also reported a decline from 91 to 75% for all adults 65 plus. Data for VE against hospitalization were more mixed. VE remained relatively high in all platforms, with a larger decline for Pfizer and 65 plus versus the 2 mRNA products combined or Moderna alone. Note that the COVID net hospitalization line overlaps with the New York State hospitalization line at the top of the graph. Next slide. I'll now move to vaccine effectiveness estimates in individuals with underlying conditions. Where these platforms also include data on individuals 65 plus, I'll include those results as well. Next slide. Supernova is a sentinel surveillance network of 5 Veterans Affairs medical centers, as shown by the map on the right. From February 1st through July 31st, investigators conducted a case control vaccine effectiveness assessment using data from these sites. Eligible participants were U.S. veterans aged at least 18 years who were hospitalized for any of these 5 sites. Cases were defined as patients with COVID-like illness, or CLI, who tested positive for SARS-CoV-2 by RT-PCR. Controls were also patients with CLI with negative SARS-CoV-2 test results. Next. Of note, while Supernova doesn't specifically target elderly individuals or those with comorbidities, given the general VA population, this group is skewed in that direction, with a median age of 67 years and almost half with a Charlson index above 3. So we've included this estimate in the group who may be at higher risk of severe COVID-19 due to underlying conditions. Next slide. This slide is the entire study period, not divided by Delta predominance. Here we see on the right in gray the difference between the younger and older individuals in the cohort for Pfizer and Moderna combined, with a statistically significantly lower VE for older individuals. In blue is Pfizer, which has a more extreme difference between age groups than Moderna in yellow. However, neither of the differences in individual products was significant. Here we see, next slide. Here we see estimates broken down by Delta predominance on the left in blue and time since vaccination on the right in yellow. Note that these estimates include all age groups in both mRNA products, and we see little change in VE against hospitalization by time period or by time since vaccination. Next slide. IVY is an active surveillance network of 21 Sentinel hospitals in 18 states. Sites enroll hospitalized adults with and without COVID-like illness, rapidly collect in-depth vaccination and clinical information, and collect respiratory samples for central RT-PCR testing and sequencing. PCR-positive cases are matched to PCR-negative controls. For this analysis of VE against hospitalized COVID-19, IVY investigators included adults admitted to IVY sites from March 11th through August 15th, 2021. Next slide. This is time since vaccination. For Pfizer, shown on the left in blue, the difference by time period is both contextually meaningful and statistically significant. Moderna in yellow does not show similar waning. There were not enough observations here to break out Janssen by time since vaccination, but we did want to include the overall estimate for comparison. Next slide. This is the same slide as before, but now with Pfizer and Moderna estimates combined and then separated by age group, under 65 on the left in blue and over 65 on the right in yellow. Here we see a decline in the 65 plus age group and no similar decline in the younger adults. Next slide. And here are the same age groups, this time by pre-Delta versus Delta instead of time since vaccination. This time there's a less pronounced decline in the 65 plus age group. Next slide. And finally, the Ivy team was able to run some analyses looking specifically at those with comorbidities in the pre-Delta and Delta periods. The analysis here excludes those with immunocompromising conditions and controls for age. On the left are in blue are individuals with no underlying conditions, in red with one or more underlying condition, and in gray and yellow individuals with hypertension and obesity, respectively. Although overall VE for individuals with underlying conditions appears slightly lower than for those with no underlying conditions, we don't see any large declines from the pre-Delta versus Delta period in any of the groups. Next slide. There were no estimates available for VE against infection for individuals specifically with underlying medical conditions. For VE against hospitalization, estimates did not vary substantially by Delta predominance. Next slide. The last group that I'll highlight today are individuals with occupations that put them at higher risk of exposure to SARS-CoV-2. While this group is likely to include many individuals such as grocery workers, educators, and restaurant workers, estimates for most professions are not available. Today I'll present data on healthcare personnel, first responders, and other frontline workers, although there should be no biological difference in VE between these groups and similar individuals in lower risk occupations. Next slide. Heroes Recover is a prospective cohort of over 4,000 healthcare personnel, first responders, and other frontline workers in 8 U.S. locations. Participants are swabbed weekly, and additional specimens are collected if a participant is ill. Vaccination is documented through multiple methods, with 95% of those vaccinated receiving an mRNA product. Next slide. In the red box, we see the VE against infection for healthcare personnel, first responders, and frontline workers in the full study period by time since vaccination. Although the confidence intervals are wide, we see some indication in the point estimates of waning immunity over time. Next slide. Now, in the red box at the bottom, we see a substantial decline in VE against infection from 91% in the pre-Delta period to 66% once Delta was predominant. Importantly, there were not enough hospitalizations in this highly vaccinated population to provide estimates for VE for hospitalization. Next slide. I'll now provide a summary of the results by risk group. Next slide. I first wanted to share the findings for the 3 risk groups together to give a sense of magnitude. Obviously, there are many more data available for adults 65 plus, but for the other 2 groups, there is not much reason to think we would have different VE than in other adults. For example, here we can see a similar decrease in VE against infection for healthcare personnel in blue on the right, and for VE against infection for 65 plus on the left. Across platforms, VE appears to decrease more for infection than hospitalization, although the Vision platform did see a decrease in VE for adults up against hospitalization, a finding which was not generally seen in younger age groups. Next slide. For individuals 65 plus, we saw significant declines in VE against infection during Delta for the mRNA products. We also saw declines, particularly for Pfizer for 65 up, that were not seen in younger populations. Finally, there's evidence of waning for VE against hospitalization in the Delta period. While an estimate specifically for 65 plus was not available, it's likely that waning for that group would be as bad or worse than in all adults. For individuals with underlying medical conditions, there was no specific data on VE against infection. However, it's likely that VE for this group is similar to that in the general population, as shown in the ICAT data at the beginning of the presentation. VE against hospitalization for those with underlying medical conditions remained high in the Delta period. For individuals with occupations with high risk of exposure to SARS-CoV-2, there were no data on VE against hospitalization specifically, although again, this is likely to be similar to that in the general population. We did see similar patterns for VE against infection for this group as we saw in the general adult population. Next slide. This presentation represents the work of dozens of individuals and teams, both at CDC and at various study sites, and I want to thank each of them for their countless hours ensuring high-quality data and analyses are available to ACIP. Thank you.
Thank you, Dr. Link-Ellis. And this presentation is now open for questions and further discussion. Are there any questions from our ACIP members? Thank you. I'll call on Dr. Lehrer first.
I just want to compliment that this is a wonderful presentation. It gave us the information, but didn't just read from the slides. It was very well done, and I appreciate the effort that went into it.
Thank you, Dr. Lehrer. I believe many of us echo that sentiment. Dr. Long.
And I echo that sentiment also. This is the key. This is the deal. These set of data are the deal. I would just encourage us not to lump infection and hospitalization because what I have said before, I don't think there's any hope that a vaccine such as the ones we have will prevent infection after the first maybe couple weeks that you have those extraordinary immediate responses. So I think it will help us because I suspect we will end up saying it's serious infection, serious symptomatic infection, and hospitalization, and certainly death that is the goal of our current program. And I probably will say more about that later, but these are the important data, and I just would not lump infection and hospitalization because the public and for healthcare workers, I mean, we shouldn't be concerned that they're giving it to other people because they should be masked and should be practicing proper distancing, hygiene, etc. And I think it's confusing for the populace who thinks that if you can get infected, then the vaccine is failing. This vaccine on the first day is, not going to be more than 80% protective against infection, just because the only protection against infection you would get is what leaches out of the parenteral circulation into the mucosa. Thank you.
Thank you for those comments, Dr. Long. I'm going to ask Dr. Beth Bell to go next.
Thank you. I actually just have a very straightforward clarifying question, which I apologize for having to ask in this incredibly clear presentation. The data about people with underlying medical conditions, is that data stratified by age group, or are these everybody with underlying medical conditions regardless of age?
Yeah, thank you for that question. So the supernova data with underlying condition is not stratified by age. They did not have the power to do that. The IV data is also not stratified by age, but they were able to control for age in their model.
Dr. Bell, do you have any follow-up questions?
No, I just wanted to make sure that we're keeping the age effect in mind when we're looking at these other subgroups. Thank you.
Thank you. I'll just ask a quick follow-up to that then. Do you have a sense of the proportions of the population that are under 65 versus over 65 in those two studies with focused on underlying medical conditions?
Sure. So in the supernova study, the median age in that group was about 68 years, just due to the underlying population in the VA medical centers. It tends to skew older than the general adult population. For the IV data, I don't have that number in front of me. It is adults 18 and older, but we can get that in follow-up.
Thank you so much. Dr. Paling.
First of all, thank you for an incredible presentation. And what I really appreciated was how many different groups are looking at vaccine effectiveness. And the point I wanted to make was to highlight the supernova data, because we've been focused on the disparities we see, particularly among race and ethnicity. And if I understood correctly, this population actually was almost 50% Black and had high comorbidities. And so that VE I thought was really important. And just wanted to say thank you.
Thank you. Dr. Brooks.
Yes, excellent presentation. One comment, I think that from the presentation before, we saw that cellular immunity seems to still be in play 6 to 8 months out. So I think that this presentation was important to show that you do have a waning of vaccine effectiveness, even if in the face of T-cell protection being high. So that's important. The question I have is, would you comment on the decrease in vaccine efficacy or effectiveness in the healthcare workers, which I presume are generally of a lower age than the general population or the elderly or the senior population? So is it because we think there might be more exposure, so just more chance of them getting infected, or what would be attributed to that?
Yes, thank you. So in the Heroes Recover data, where we saw VE for infection decrease from 91 to 66%, I would say that in a lot of other studies, this one included, I think we have information that most of those infections are actually community acquired, not acquired on the job. And I would just point back to the ICAT data that I showed at the beginning of the presentation, which is the general population. And they saw pretty similar steep declines in VE against infection in particular, regardless of age group, and again, in the general population, not specifically to healthcare workers.
Thank you so much. Oh, Dr. Brooks, did you have any other questions?
No.
Okay, thank you. I'm going to thank Dr. Duchin for waiting patiently. Dr. Duchin, please go ahead.
Thank you, Dr. Lee. I have a couple of questions. The first one is for the COVIDnet hospitalization data, the risk factors. I did not see obesity listed, and I'm just wondering if that's because it did not rise to the level of any increased risk, or it wasn't assessed.
I don't have that number in front of me, but I can follow up with it.
Okay, thank you. Then my second, I have two more questions. One is, do these vaccine effectiveness studies account for prior COVID in the unvaccinated populations?
Right, so most of our studies were able to exclude prior infection. COVIDnet, for their VE estimates, because they were doing a screening method, they were able to exclude individuals that were hospitalized with prior infection. But then, of course, for the non-hospitalized group, they're using an ecological analysis of that group, so they don't have individual level data for the comparison group on prior infection.
Okay, but for instance, the VA studies,
right?
They exclude, and they have a way to accurately identify and exclude those with prior COVID.
Right, for all the individual level platforms, so the VA Medical Center, IV Vision, they do exclude individuals with prior infection.
That's great, thank you. And then my last question is, can you comment on some of the differences between the data we're observing from the US and what have been reported from other countries, in particular from Israel?
Sure. So I believe that Dr. Oliver will include some of the international estimates in her presentation later today. But I would just point back to some differences between both the populations and the methods that are used in the analyses in Israel versus the US. The biggest one, I think, is the difference in how we define severe disease. So the Israeli data can include outpatient individuals in the severe disease based on respiratory rate, whereas in the US, we almost across the board use hospitalization as our definition for severe. So I think that will change quite a bit the estimates and skew the Israeli estimates a little more towards what we see for infection.
Thank you.
Thank you. One more question. So looking at the variety of studies, so first of all, I think you did a wonderful job trying to help us understand the impact of time-varying confounding on vaccine effectiveness, and it's really complex with the various data and populations that are available. One question I had is, in the healthcare personnel cohort, it seemed like Delta had a bigger impact. I think in the IV cohort, it seemed like perhaps time since vaccination had a slightly bigger impact. Are you able to maybe provide an understanding of, what might be most relevant to what? Is it differences in population? Is it really due to those time-varying confounders? Is it a combination of both?
Sure. In the end, I think some of it is just different methodology and the fact that really neither HEROES nor IV was able to truly tease apart time since vaccination from Delta. So they weren't able to do the cross-tab of looking at time since vaccination in the pre-Delta period and then time since vaccination in the overall. They looked at time since vaccination in the entire cohort and then separately pre-Delta versus during Delta. And I think that can skew depending on, so for example, the HEROES Recover, since it focuses on healthcare workers, many of those individuals would have been vaccinated much earlier than the general population included in the IV analysis. And since we can't tease apart that pre-Delta, post-Delta, it's a little hard to parse out. I think the clearest one for that particular question is the vision analysis, since they actually did have enough observations in the Delta period to look at waning over time since vaccination during Delta, and they did see that statistically significant decreasing trend.
Thank you. Are there any additional questions from our ACIP members, ex officio members, or liaisons?
There's a response in chat about obesity.
Okay. Would you like to comment? I think Dr. Havers commented specifically on COVIDNet.
Yes, thanks, Dr. Havers, who's the CDC PI for COVIDNet, addressing the earlier question about obesity. They did assess it in COVIDNet, and it was not significantly associated with being hospitalized after vaccination in individuals under 65 or in individuals 65 and up.
Terrific. Dr. Weiser.
Hi, good morning, Dr. Weiser from IHS. Thanks for that presentation. And I was just wondering if you have any additional data on American Indians and Alaska Natives with regard to vaccine efficacy or waning. We know that American Indians during the pre-vaccine era were more heavily impacted, especially at younger ages. So hospitalizations and deaths seem to peak at a younger age than the general population. And just wondering if you have any additional information or if anyone is making an effort to try and gather that information with regard to American Indians and Alaska Natives and vaccine efficacy or waning. Thanks.
There is a platform that focuses specifically on vaccine effectiveness in this population. Unfortunately, the population is so small that they haven't had enough cases in that platform at this time to provide estimates.
Thank you, Dr. Link-Ellis. Are there any additional questions or hands raised? I just want to confirm that these are hands that have been raised previously. All right. Well, thank you so much, Dr. Link-Ellis. I also want to just take a moment to thank you and your collaborators for putting together this really excellent presentation, but also all of the investigators from each of the studies that are ongoing. Because this data is so critical, and we really appreciate your ability to help us wade through the data and understand it better, again, to support decision making. So really appreciate everyone's efforts on this. And now we'll turn it over to Dr. Rachel Slayton, who will be discussing modeling the potential impact of booster doses in nursing home residents. Dr. Slayton.
Good afternoon, and thank you, Dr. Lee. Next slide. Today I'll be covering our mathematical modeling of SARS-CoV-2 transmission in nursing homes. Next slide. We'll start by looking at the similar trends in COVID-19 incidence in nursing homes in the community. This graph depicts the weekly incidence in the community in gray on the left-hand y-axis and in nursing homes on the right-hand y-axis. It highlights that outbreaks in the community and nursing homes are linked and that controlling community transmission is important for protecting the vulnerable nursing home resident population. Next. To better understand SARS-CoV-2 transmission in nursing homes, we developed a model in collaboration with our colleagues at the Harvard T.H. Chan School of Public Health, in particular Rebecca Kahn and Inga Holmdahl, which builds upon previously published work referenced on this slide. We model an average US nursing home with 100 residents and 100 staff members. In this analysis, the nursing home is fully occupied with resident turnover explicitly modeled using resident length of stay data from the Centers for Medicare and Medicaid Services. Cases are introduced into the nursing home by staff who have a daily probability of infection from their time in the community, which is directly estimated from National Healthcare Safety Network or NHSN data. Transmission within the nursing home is stochastic. It is based on the number of contacts individuals have each day, the probability of transmission given a contact with an infectious person, and the total number of infectious individuals in the nursing home each day. Following guidelines, non-outbreak screening testing of unvaccinated staff is conducted twice per week, and once an outbreak is identified, this shifts to twice weekly testing. We look at 4 main outcomes over a 2-month period in our analysis. The total number of symptomatic cases, both in residents and in the entire nursing home, so including both residents and staff, and the total number of infections in residents and in the entire nursing home. We repeat our simulations 100 times to capture variability. The table to the right of this slide shows some key parameters from the model. We assume a basic reproduction number, or R0, of 6, reflecting estimates for the more transmissible Delta variant. As previously mentioned, the staff have a daily probability of infection from the community, which we vary from moderately high to high. 80% of residents, both those in the nursing home at the beginning of the simulation and those that enter the nursing home during the simulation, are vaccinated, and we vary staff vaccination coverage from 40 to 100%. We then look at several values for vaccine efficacy, or VE. First, the 2-dose VE against infection for staff is 70%. We vary the 2-dose VE against infection for residents from 50% to 70%, reflecting some data which shows that there is a lower VE among older populations. The vaccine also has efficacy against progression to symptoms, and we assume that VE against symptomatic disease for staff is 90% and vary the same parameter between 80 and 90% for residents. We assume that VE against infectiousness or transmission for both residents and staff is 50%, which means that infections in vaccinated persons are half as infectious as those occurring in unvaccinated individuals. We also model the introduction of booster doses, which take 2 weeks to take effect, and we systematically vary their efficacy from 60 to 90%. Next slide. So let's start by looking at the cumulative incidence among residents after 2 months by symptom status and vaccination status. In these simulations, resident coverage is 80% and staff vaccination coverage is 60%. We have not yet introduced boosters into these simulations. The graphs show the distribution of cumulative incidence among residents after 2 months across those 100 simulations. So the x-axis here is showing the number of infections among residents, not time, and the height of the bars reflects the density of simulations for each number of cases observed in the nursing home. The left panel shows a moderate daily importation rate. Remember, this is that staff daily probability of infection in the community. And the right panel shows a higher daily importation rate, reflecting higher community transmission. The green on the graph shows the number of infections among vaccinated residents, with the darker shading indicating symptomatic infections and the lighter shading indicating asymptomatic infections. You can see that the majority of cases in vaccinated residents are asymptomatic due to the vaccine's efficacy against symptoms. And the blue on the bottom of the graph shows the distribution of the number of cases among unvaccinated residents, again with the darker shading showing symptomatic cases and the lighter shading showing asymptomatic cases. Of note, while only 20% of residents are unvaccinated in these simulations, they contribute a large share of symptomatic cases. We see that a higher daily importation rate results in more nursing home cases, and this highlights that an increase in nursing home cases does not necessarily indicate lower or waning VE if community transmission is increasing during the same time period. Next slide. We'll add to the same figure two additional panels which evaluate the cumulative incidence when VE against infection for residents is higher, here assumed to be 70%. We see similar trends as in the top two graphs. The curves are shifted to the left, reflecting lower cumulative incidence overall, which we would expect when VE is higher. Next slide. I'll now show results from simulations assessing the impact of varying levels of staff vaccination coverage and providing all residents a booster dose with varying VE. Next slide. Here we'll start by looking at the number of symptomatic cases among residents. The left panel shows simulations with the moderate level of staff importation, and the right panel shows a higher level reflecting higher community transmission. In these simulations, there are no boosters given, and VE against infection in residents is 50%. The y-axis shows staff vaccination coverage, which we systematically varied from 40% at the bottom to 100% at the top. The colors reflect the average number of symptomatic residents after 2 months and across those 100 simulations. The lighter tiles show fewer numbers of symptomatic cases among residents, and the darker tiles show higher numbers. As expected, higher staff vaccination coverage, shown in the top row here, results in fewer symptomatic cases among residents. The cumulative cases are highly dependent on community transmission, which we can see when we compare the left versus the right panels. For context, over those 2-month period that we're modeling here in this 100-bed nursing home, on average, there were 217 unique residents over the entire time period, because the median duration of stay, as modeled here, was 27 days. Next slide. Across nursing homes in the United States, NHSN data finds that the average staff vaccination coverage is just above 60%. So you can see that in the third row from the bottom, when we look at this row, we can see the impact of increasing staff vaccination coverage from above that national average when we look up in the graph. Next slide. We'll now begin to look at simulations that include boosters. The first column here is identical to the previous slide and shows simulations without a booster where VE against infection in residents is 50%. The x-axis shows the resulting VE against infection after the booster dose is given to all vaccinated residents. Staff are not receiving a booster dose in these simulations. As a reminder, 80% of residents are vaccinated and all of them receive a booster dose, but we vary the efficacy of that booster. If we move to the second column of each panel here, the simulations are showing that boosters that increase VE against infection from 50% to 60% in residents. And as expected, the color of the tiles gets lighter as we move across that x-axis from left to right as we increase VE against infection post-booster. We find that higher staff coverage and higher booster VE against infection, or that top right quadrant of each of these panels, leads to fewer symptomatic cases among residents. Similar to our previous findings, cumulative symptomatic cases among residents are highly dependent on the community transmission when we look across the two panels here. Next slide. We'll now look at a similar set of figures, but this time the outcome depicted is total symptomatic and asymptomatic COVID-19 infections among residents. There are higher absolute numbers of infections when we look at the scale here. but the trends remain largely the same. Once again, we see that higher staff coverage and higher booster VE leads to fewer infections. Next slide. We'll also look at symptomatic COVID-19 cases in nursing homes overall, including both residents and staff. We see similar trends when looking at all symptomatic cases in the nursing home as compared with looking at residents only on the previous slide. Of note, these graphs show a larger impact of increasing staff coverage because they are incorporating the direct protection the vaccines provide to staff, in addition to the indirect protection staff vaccination provides to nursing home residents. Next slide. Finally, we'll look at total infections, including asymptomatic and symptomatic infections in the nursing home overall, which includes both residents and staff. We see similar trends as we did when we look at total infections in residents. However, there are higher numbers of infections than previously shown. Next slide. Our analysis is subject to a number of limitations. We modeled VE against infection, VE against symptomatic disease, and VE against infectiousness as point estimates. These estimates are likely to vary by a number of factors. For example, vaccine type, age of vaccinated persons, and immunocompromising conditions of vaccinated persons. So the analysis shown here is most appropriate when we're considering the potential impact of providing booster doses for nursing home residents who received an mRNA vaccine. We modeled an average nursing home that did not capture all of the facility level heterogeneity that exists. Additionally, previous COVID-19 infections are not explicitly modeled, which may underestimate the level of prior immune protection independent of vaccination. And we do not explore the impact of vaccine supply shortages in this model. Next slide. So in summary, you'll see that we find that maximizing vaccination coverage among nursing home staff remains a critical tool for preventing cases in nursing home residents. Our simulations also show that boosters for nursing home residents can help reduce cases, but the magnitude of their effect depends on what that boosted VE is. Even with highly effective boosters, if community transmission is high in our models, that suggests that there will still be COVID-19 cases in nursing homes, highlighting the need for continued infection prevention and control strategies. Thank you.
Thank you, Dr. Slayton, for presenting the results of that model. I'll invite this presentation. It's open for questions now. And I actually wanted to perhaps start out with one comment or observation from the modeling that I think is really instructive. And also, I think clear to many of us, but I think the model makes it even more explicit, which is that community rates can really make a huge difference. So it not only matters to us as individuals, whether you're vaccinated or unvaccinated, what your community rates of transmission are, which have absolutely a direct impact on us. But for many of us who work in healthcare facilities, we have, as community transmission rates have gone up, have had to reinstate visitor restriction policies, which means family members can't come visit their loved ones. Similar for nursing home settings. And in addition, it impacts our schools. We see clearly where transmission rates in the communities are higher. We are seeing higher rates of infection occurring in schools as a reflection of the broader community. So really appreciate that your model illustrates that so well. And it also behooves us to not only want to achieve individual protection, but also community level protection. I wanted to invite our colleagues on the call to see if there's any additional questions from ACIP members, ex officio members, or liaisons. Dr. Paling.
So I wanted to say thank you for a beautiful study, and I agree with you, Dr. Lee, that the impact of the community transmission is really huge and beautifully exemplified. I also just wanted to reiterate the point you beautifully made about how staff coverage actually makes a bigger difference than does the booster dose among the residents. And I just wanted to thank you for illustrating that point. It's really important.
Thank you, Dr. Paling. Dr. Chen.
Yeah, I wanted to also thank you for just a terrific presentation of modeling information, which I always find difficult to understand, but you did it very well, communicated it. So what I think I understood was, staff coverage made a bigger impact than resident coverage. And I guess what I take out of that is if you also generalize this to the population, it's not about, an argument of only thinking about personal protection, but that the indirect protection that is to be gained in a population is, more effective when you have higher numbers in the population being successfully vaccinated. And I think the second point that you made very clear to me was that those community rates, those localized community rates were so important also to bringing out the vaccine effectiveness. So I guess that's my statement. Maybe you can correct me if I made those conclusions wrong. But I guess my question is whether or not we can also use some of this modeling for understanding pediatric populations, say, for example, schools that largely remain unvaccinated because of younger children, especially in the elementary schools, or if maybe there are further modeling exercises that are being done internally to help us understand this as well. Just trying to, again, understand the impact in all segments of populations, and maybe I'm also drawing just too many conclusions from this single modeling exercise. So I'll just stop there and let you comment.
Thank you, Dr. Chen. I think that your summary of the main conclusions of today's presentation is correct. And I echo that the staff vaccination coverage is important and influential. The staff have contacts in the community and can import COVID-19 into the nursing home facility. So increasing staff vaccination coverage is incredibly important. As to your other point about the role of children in the epidemic size that we might see, we're collaborating closely with a consortium of modeling researchers at the COVID-19 scenario modeling hub to look at longer term projections that makes different assumptions about whether or not vaccines become available for children 5 to 11 and what the impact might be on the longer term trajectory there. So we'll be happy to share those with you all in a future discussion.
Terrific. Thank you so much. Dr. Kimberlin.
David Kimberlin, AAP Red Book. A comment only about community transmission. I think all you really have to do is look at the CDC's maps by counties to see what areas of our country are most red in terms of highest rates of transmission in the community. And at least in many of those communities, arguably most of those communities, there really are not efforts within the community to enforce or even strongly encourage masking indoors and other kinds of things that would mitigate transmission within the community. That's probably the reason they're the most red. And my comment to the ACIP is, as you consider, if and how to apply these modeling results, I don't think we can count on communities to re-implement, many communities within our country to re-implement masking. I just don't see it happening, at least in my region of the country. Only a comment, doesn't require any kind of feedback, and it's just my opinion.
Thank you, Dr. Kimberlin, and appreciate this is going to be a multi-pronged approach we'll need to take together. Dr. Zahn.
Thank you, Dr. Lee, and thank you, Dr. Slayton, for a great presentation. I would just note that the information Dr. Slayton was talking about here in modeling in nursing homes is really being lived out right now in communities around the country for local public health and for nursing homes. Somewhere in the summertime, in between when the Delta variant arrived or waning immunity or some combination there, it became very clear that even if you were fully vaccinated, particularly if you have a household exposure, your chance of having breakthrough infection is not trivial. And that becomes a difficult calculation for staff working, particularly in skilled nursing facilities, where the risk of introducing the virus there is so great. And so for all of us, standard practice is if you're vaccinated, you are immune, and if you have a community exposure, it's okay, you can continue to work. But that's a difficult calculation, and any measures that we can think about to assure immunity as optimized in that staff population, I think we really have to think hard about it.
Thank you. Thank you, Dr. Zahn. Dr. Slayton, any additional comments?
No, thank you, Dr. Zahn.
Okay. Dr. Maldonado.
Thank you, Dr. Slayton. That was really a wonderful presentation. It really highlights some of the key epidemiologic issues that the other commenters have pointed out. I want to reinforce what was said about future modeling, especially for the pediatric population, and given what's happening with return to school, and as you heard, some of the restrictions that are being placed on masks in some of these populations. And so really trying to make a case for or against, as you do so well, the risks and the benefits of vaccination of not only 5 to 11-year-olds that we're going to be seeing hopefully soon, but especially for the under 5-year-olds, where I think there has already been a lot of undercurrents in the lay press and across social media around the necessity or not of vaccinating that population. So again, we want to be sure that we have all of those data available when and if we are able to consider the pediatric population and transmission within their, especially within their school settings, and given the high background rate of transmissions that can occur within some of the high-risk communities where equity may be a particular concern. So we really appreciate this and hope to continue to see this type of modeling for other populations as well.
Thank you, Dr. Maldonado. Dr. Duchin?
Thank you, Dr. Lee. My question is about the conclusion, which I agree with, that even with highly effective boosters, we'll need continued infection prevention and control strategies. Clearly, vaccination of staff is absolutely critical. Did you consider looking at testing strategies and what the impact of, for instance, frequent screening, rapid antigen testing would be on staff, on the incidence of COVID-19 among the residents?
Thank you, Dr. Duchin. We previously looked at questions around what that frequency of testing might look like in our CID paper before there were data about what the various VE values would be. We did a wide parameter sweep for the 3 VE types that I described in our presentation today, and looked at trade-offs with timeliness of results, with sensitivity, to try to better understand what that might do to the magnitude of transmission in nursing homes. I'll point out that in the presentation today, even if we're looking in that upper right quadrant with very high staff vaccination coverage and very high VE against infection for residents after boosting, we're still seeing non-zero values. And on the right-hand panels, when we saw more community transmission, those importations are more frequent, highlighting the rationale, I think, for increasing the frequency of testing in nursing homes when there is more transmission in the community, to have early identification of those importations and to implement additional infection prevention and control measures to mitigate further spread.
Thank you for reiterating and clarifying that really important point. I appreciate it.
Thank you. Dr. Zimmerman?
Rick Zimmerman. Nice presentation. The one question that I had is if you'd had a chance yet to model different facility size. I could, I guess, think about possible differences in a large versus a small facility size, given the potential for density and effects on of infectiousness. Did you have a chance yet to look at that?
We haven't yet explored all the facility level heterogeneity. I also wonder that if in the very large nursing homes that tend to have perhaps more segregated staffing across buildings or across floors, if some of those effects might be more limited in transmission across buildings, for example, perhaps, but it's an interesting question to explore in future work.
Thank you. Dr. Foster.
Thank you, Dr. Lee, and also thank you, Dr. Slayton, for a great presentation. As always, we want more data than is possible to obtain. That's our general nature here. But often we hear reasons that we don't want to get vaccinated because of herd immunity. Is it even possible to factor in a herd immunity factor into these type of calculations?
Thank you, Dr. Foster. I think there's a way to estimate what that critical vaccination threshold might need to be based upon what the reproductive number is. But there are also important issues that you all are aware of with the emergence of novel variants, where there may be a different level of sort of cross protection for persons who were either vaccinated or had an infection with a previous variant. There are also issues about the time horizon and if questions about waning immunity, again, from either natural infection or from vaccination ought to be incorporated there. For an infectious disease with an R0 6 or higher, which is what we're estimating for Delta, it's a very high threshold, and it's even higher perhaps when you think about the heterogeneity that I just described.
Thank you, Dr. Slayton. Dr. Duchin.
Thank you. Just a follow-up question. I think this point about the need to have, layered prevention measures is really important. And, talking about vaccination and infection control strategies, testing. One really important one that we haven't talked about is ventilation and improving the indoor air quality. And I'm wondering if that was something your team considered. I know that there was some modeling around schools and ventilation, but knowing what we know about the quality of indoor air in long-term care facilities, can we understand what type of benefit we might receive if we could achieve, let's say, 4 to 6 air exchanges per hour, in addition to the other measures?
That wasn't explicitly included here because in nursing homes with the level of mixing that we would expect with resident meals, with group activities, et cetera, shared rooms, we did not explicitly evaluate that when thinking about the effective contact rate. Again, an interesting, perhaps, future direction.
Thank you.
Thank you. Dr. Slayton, one question from me. And I don't think we're quite here yet, but right now, where we are with the booster vaccination program and really thinking about the prevention of severe disease, I guess my question to you is, at what point in the pandemic and in our overall vaccination program for the U.S., and recognizing there's importation globally, but for the U.S. for the moment, when do you think it might be appropriate to consider modeling to understand the impact of a booster vaccine on decreasing transmission, in addition to decreasing the risk of severe disease? And I ask because I think that right now our biggest area the biggest sort of opportunity for us continues to be in ensuring that we're vaccinating the population that is unvaccinated, so getting from 0 to 2. But it would be wonderful to be able to know when it might be possible to go from 2 to 3 and use a slightly different strategy. I'll also just take a moment to ask our colleagues in industry about continued innovation in this space, because I think that, again, I anticipate boosters will be inevitable, but the ability to achieve sterilizing immunity perhaps is something that would be a worthy goal to achieve in order to be able to also address this question in the longer term.
I'll start and say that by looking at the outcomes of symptomatic COVID-19 cases and then total infections, that was one way we were hoping to provide you all with some data to help think through what's happening with transmission versus disease in the nursing home population. Additionally, if there is a recommendation for booster doses, then one could adopt that in some of these larger scale population models to look at what the impact might be population-wide. If those booster doses are primarily going to be in older adults, then they tend to have less contacts than other age groups. And so it's where we are in the pandemic that affects, the magnitude of that effect may be small, moderate, is my best hypothesis there. I think additionally, it's a worthwhile endeavor to think about multi-year time horizons in the models to think about where we end up with COVID-19 in the longer term. Doing that accurately with a novel pathogen that's rapidly changing, as we've seen with the novel variants, is a difficult endeavor, but we continue to work on it along with our colleagues in academia and industry to help move this fight forward.
Thank you, Dr. Slayton, and thank you for trying to answer impossible questions that we ask. All right, are there any other questions from our liaisons, ex officio, or ACIP members? All right, well, seeing none, I would suggest that we would adjourn for a break and plan to return. Yes, I think we'll plan to adjourn until 2 p.m. as planned, and we'll come back and discuss vaccine safety. Thanks very much.